My name is Michaela Phelps, and I am a fourth-year pharmacy student at Drake University. Currently, I am on an internal medicine rotation. Today, my presentation will answer the question, does dexamethasone make a difference in COVID-19? First, we will start out with the background on dexamethasone. Dexamethasone is a corticosteroid that is typically used as an anti-inflammatory or immunosuppressant medication. Coronavirus, or COVID-19, is an infectious disease that can result in acute respiratory problems as well as other acute medical conditions. COVID-19 complications have come from an immune response as well as a hyperinflammatory response. Corticosteroids can impact immune-mediated lung injury and could potentially decrease risk for respiratory failure and death. This information leads us to the explanation as to why corticosteroids could be considered an option within cases of COVID-19. Steroid use has been previously studied in influenza, pneumonia, and acute respiratory distress syndrome, or ARDS. As you can see in the first column, corticosteroid therapy in influenza was associated with a higher mortality and a higher incidence of nosocomial infection. From the second column, you can see that corticosteroid therapy in adults with severe community-acquired pneumonia reduced morbidity and mortality. However, in adults with non-severe community-acquired pneumonia, corticosteroids reduced morbidity but not mortality. Although these results are promising, corticosteroids were also associated with severe adverse events, notably nosocomial infections and hyperglycemia. And as you can see from the third column, corticosteroid use in ARDS was shown to reduce time to endotracheal extubation, duration of hospitalization, and mortality. In the DEXA-ARDS study, the mean number of ventilator-free days was higher in dexamethasone than a control group and mortality was lower. Overall, steroid use in ARDS has been shown to decrease duration of mechanical ventilation and mortality. In conclusion, current data does not support the routine use of corticosteroids in patients with influenza, severe pneumonia, or ARDS. This leads us to the recovery trial. The recovery trial is a randomized, controlled, open-label evaluation of COVID-19 therapies in over 11,500 patients. The study compares therapies of topinavir-ritonavir, hydroxychloroquine, azithromycin, and corticosteroids. Early results will release for the 2014 patients who were randomized to receive steroids versus usual care alone. Dexamethasone was likely chosen for use out of the corticosteroids as it is a highly potent and long-acting medication. It was given at 6 milligrams per day for up to 10 days and was available for administration as an oral or intravenous preparation. The primary outcome was 28-day mortality. Dexamethasone was shown to reduce deaths by 1/3 in mechanically ventilated patients and to reduce deaths by 1/5 in patients receiving oxygen without invasive mechanical ventilation. It did not provide benefit in patients who did not require respiratory support. As a result of the recovery trial, new IDSA guidelines for treatment of COVID-19 patients with dexamethasone were developed. Now on to the IDSA guidelines. Among hospitalized patients with severe COVID-19, the IDSA guideline panel suggests glucocorticoids rather than no glucocorticoids. Dexamethasone 6 mg IV or oral for 10 days or an equivalent glucocorticoid dose may be substituted if dexamethasone is unavailable. Equivalent total daily doses of alternative glucocorticoids to dexamethasone 6 mg daily are methylprednisolone 32 mg and prednisone 40 mg. Among hospitalized patients with COVID-19 without hypoxemia requiring supplemental oxygen, the IDSA guideline panel suggests against the use of glucocorticoids. Although these results are promising, there are still risks to using this corticosteroid. In the acute care setting, it is important to watch out for adverse drug events. We should be monitoring glucose, weight changes, signs of infection, and psychiatric effects. Prolonged use of systemic corticosteroids can increase the risk of reactivating latent infections such as hepatitis, herpes, strongyloides, and tuberculosis. Administration of dexamethasone and remdesivir have not been studied. In conclusion, the recovery trial shows compelling evidence for steroid use for COVID-19, including dexamethasone. As of June 25, 2020, the IDSA recommends use of dexamethasone for hospitalized patients requiring supplemental oxygen or mechanical ventilation. Guidelines rapidly change, as well as the state of the pandemic. It is important to keep up to date on all things COVID-19. More data should be forthcoming from this large randomized trial to guide further therapy recommendations. Here are my references, and thank you so much for listening to my presentation.